it endangers the life of the mother, or if there's, a case of rape or incest. Whereas the more protective states might say insurance has to cover it if it covers any kind of prenatal care. And then oops, you guys are seeing my pop-up. And then in the more restrictive states, there might be limits on emergency contraception, which again, Plan B is not the abortion pill. Plan B just inhibits ovulation. And 9 states have limited coverage of contraception, or they might allow pharmacists to refuse to dispense Plan B. Those kinds of things might happen in those more restrictive states. And please feel free to chime in if anyone has any questions at any point. I do have one break in the middle to allow some discussion, but please chime in if there are questions or thoughts as we go along. So I took that same map and I zoomed in here on Minnesota because I think it's important to note that we're surrounded by states that are more restrictive about abortion access, and we need to think about what implications that's going to have for our state. Planned Parenthood North Central states share that there's been a 100% surge in patients from outside the region since Roe was overturned a year ago. There's also been a 19% increase in second trimester abortions, mainly with patients from states where an abortion ban and restrictions went into place after Roe fell. In Bloomington, Whole Women's Health reported that nearly 42% of their clinic's patients were from outside of Minnesota at the end of 2022, which is up from 20% in previous years. So we're seeing a lot more women come to our state to get abortion care. We're really viewed as a safe haven state in the Midwest. And of course, you got to think about what effect does this have on our own women in Minnesota. With this surge in demand, that can create delays for Minnesota women who need abortion care. So bear with me, this slide is probably my longest slide, but I think it is important to have an understanding of the history of abortion in the United States to kind of understand what's happened since then or after then. So I'm going to go just highlight some major points in the history of abortion. So in 1821, Connecticut passed the first law in the U.S. to restrict abortion. It prohibited the use of a toxic substance to cause a miscarriage after quickening. And then jump to the 1930s, the number of abortions increased significantly during the Great Depression. And so the dangerous practice of unregulated abortions led to a high U.S. maternal mortality rate. In fact, a study done in 1931 showed that illegal procedures were responsible for 14% of maternal deaths. In the 1950s, hospitals started to form therapeutic abortion boards to decide whether doctors could perform an abortion on a case-by-case basis. Basically, they said abortions would be allowed if the mother's life was in danger, and the board would decide, in this case, is their danger to the mother's life. In 1955, Planned Parenthood organized a conference called Abortion in the United States, and that really helped launch a national discussion on reforming abortion laws. In 1962, Sherry Finkbein, an Arizona mother of 4, traveled to Sweden after a local hospital denied her request for a legal abortion. She had taken the drug thalidomide. Does anyone remember what happened with thalidomide? Does anyone want to share?
From my understanding of limb loss, is that right?
Yep, it was linked to birth defects. So thalidomide was put on the market in 1958, and it was taken off the market by 1961 because babies were being born blind, deaf, and literally with no arms and legs. So it was 1962, she had been taking the drug. It just came out that this was linked to severe birth defects. And she's like, well, I've been taking that drug. So she wanted an abortion, but Arizona would not let her have one. So she pursued that in Sweden, and that became a hot point in the discussion on legalizing abortion. In 1970, or by the early 1970s, about 20 states had passed abortion reform or repeal laws, and 4 states had legalized abortion. And then in 1972, the Supreme Court legalized the use of birth control pills for all women, regardless of marital status. Prior to that, only married women were allowed to receive the pill through a doctor's prescription. In 1973 is that landmark case Roe v. Wade. And there was actually another big case, Doe v. Bolton, which is supposedly just as important as Roe v. Wade. It just doesn't get talked about as much. So Roe v. Wade declared abortion to be a right to privacy issue, and I'll explain what that is in just a bit. And then Doe v. Bolton, they determined that hospital therapeutic abortion boards were unconstitutional. So basically in Doe v. Bolton, they said that restricting access to abortion with these boards violates the rights of women to access healthcare and of physicians to practice independently. They should be able to make decisions about, when a procedure is medically necessary for a patient. So going back to that Roe v. Wade case, so we just kind of all have understanding of what really happened in that case. It actually started in 1970 when Jane Roe, and Jane Roe was a fictional name used to protect the identity of who we now know as Norma McCorvey. Jane Roe instituted federal action against Henry Wade, I'm sorry, and he was the district attorney of Dallas County, Texas, which is where she lived. At the time, abortion was illegal in Texas unless it was needed to save the life of the mother. Her lawyers argued that she was unable to travel out of state to obtain an abortion and that the law was too vague and infringed on her constitutional right to privacy. So for me, I'll tell you, I was born in the 80s and I'm kind of like, what is this big privacy issue? Does it have to do with like medical privacy? Does it, like HIPAA? Like, what is it? When I looked into it, it's actually more about individual liberty. So the big theoretical question is, do we place personal and moral decisions in the hands of individuals or in the hands of the government? And so this case really connected back to those discussions in 1972, where they said individuals should have the freedom to decide how they want to procreate, how they want to rear their children, if they want to use contraception, who they want to marry, and if they want to consent to sexual activity. That should be left to individuals and determining if this is right or wrong. Now, I will tell you that she and her team didn't get everything they wanted in Roe v. Wade. They actually were saying there should be an absolute right to terminate a pregnancy in any way at any time. But the Supreme Court balanced that side of things with the state's interest in regulating abortion. And so this decision didn't actually legalize abortion, but it changed the way states could regulate abortion. And they specifically went trimester by trimester. They said first trimester, a state cannot regulate abortion other than requiring that the procedure needs to be performed by a licensed doctor in medically safe conditions. During the second trimester, the state can regulate abortion if it's reasonably related to the health of the pregnant person. And then during the third trimester, the state's interest may outweigh in protecting that potential human life may outweigh the right to privacy. So in the third trimester, the state can prohibit abortion unless it's medically necessary to save the mother's life. And then finally, the last part of this brief history of abortion more recently is that legislation that came through Dobbs versus Jackson Women's Health last year. So Mississippi instituted the Gestational Age Act, which banned abortion after 15 weeks. And in Dobbs, Mississippi asked that the Supreme Court overturn Roe v. Wade. This was the first time this had happened. And the opinion was released on June 24th, 2022, which handed regulation of abortion back to the states. They overturned Roe and said each state can decide what they want to do. Since then, many states have tightened their abortion restrictions and essentially made it so their residents cannot access abortion services. So let's specifically see what happened 1 year post-Roe. And it's important for us to know what's happening in other states because their laws can affect us. As we discussed, with our surrounding states having restrictions on abortion and making it inaccessible, we're starting to see an influx of women seeking abortion care in our state. The other outcome that could come from those changes, we may see an increasing number of self-managed abortions in those other states, women using hangers or ingesting drugs, or even throwing themselves downstairs. These are all things that happened prior to Roe v. Wade. Those women could potentially seek care in our state if those illegal abortions go wrong because they don't want to be charged criminally for attempting abortion. So those are things that could come from seeing restrictions surrounding us. So I'm just going to go over what I have on here, some of the changes that have happened in the last year. So abortion is now completely banned in 13 states. In Wisconsin, abortion is unavailable because of ongoing legal complexities. In Arizona, there's a ban on abortion at 15 weeks. In Georgia, there's a 6-week ban on abortion. In Ohio, abortion is legal up to 22 weeks. But there's a 6-week abortion ban in effect. In Utah, there's an 18-week abortion ban. Actually, let me go back and note one thing real quick. So in Georgia, the 6-week abortion ban, so several states have that 6-week abortion ban. And I just want to note that that's so restrictive. It's essentially like having a full ban on abortion, because you have to remember that gestation starts from the first day of your last menstrual period. So by the time the woman misses her period, around week 4 or 5, does the pregnancy test and actually seeks out abortion care, they've often missed that 6-week mark. So just also keep that in mind as you hear about the different restrictions in place. In other states, so in Wyoming, there was a trigger law that would have banned abortion in this state, but it's actually been blocked by their state Supreme Court, but that could change any day. In Florida, I think this was updated recently. There was a 6-week abortion ban signed in April 2023. Their state Supreme Court was deciding whether this would be upheld. I believe they shot it down, so it's a 15-week restriction, but I don't know if discussions are ongoing. In Nebraska, a 6-week abortion ban failed when one Republican legislator voted against it, but a ban on abortion at 12 weeks was passed as an amendment to a ban on gender-affirming care. In North Carolina, a 12-week abortion ban is set up to go into effect on July 1st. And then in South Carolina, there's a 6-week abortion ban that was signed into law in May 2023, but it's temporarily blocked following a legal challenge. Post-Roe, there have also been attacks on medication abortions. So in Arkansas, there's a new law that threatens physicians with loss of their medical license if they mail medication abortion pills. In Florida, as part of that recent discussion, they were also trying to pass legislation banning mailing medication abortion pills to patients. Montana passed a new law effective this October that requires new reporting requirements for mifepristone that is not required for other drugs or procedures. Wyoming banned medication abortion with limited exceptions effective July 1st. And then there's also a legal case with national implications. The Alliance for Hippocratic Medicine, the U.S. Food and Drug Administration, is attempting to revoke FDA approval for mifepristone. Just a little bit of background on what those medications are for. So mifepristone is one of 2 medications that make up what we consider the abortion pill. So this is not Plan B, this is actually the abortion pill. Mifepristone blocks the hormone progesterone, which causes the lining of the uterus to break down and pregnancy can't continue. And then misoprostol is taken about up to 48 hours later and causes the uterus to empty. And that would cause like a heavy cramping period. It would feel like an early miscarriage. And those medications are typically used up to 70 days or 10 weeks after the first day of the last menstrual period to induce abortion. A couple other items I just quickly want to note post-Roe. These are just further attempts to further restrictions to ban abortion. So actually this one, the first point happened prior to the overturning of Roe, but it relates. So in September 2021, Texas passed Senate Bill 8, which empowered any private individual to sue anyone who aided and abetted an abortion in Texas after 6 weeks gestation. And I wanted to point this one out because this was kind of Texas's way of working around Roe v. Wade. Because remember, we talked about it's a right to privacy issue. Do we leave this up to individuals, or do we allow the state to say this is unethical, we need to restrict this? Right? That was the big Roe v. Wade discussion. And with this private lawsuit, basically Texas is saying, we're not saying that people can't have their abortions. We're saying this is a civil matter and private individuals are allowed to handle this. If the government isn't the one deciding, if this is legal and doling out consequences. So that was kind of an attempt to work that around. And then with the overturning of Roe, it kind of brought up this conversation again. And then with the overturning of Roe, now Texas has a full ban on abortion care. And then in April 2023, this one's kind of interesting. Idaho passed House Bill 242, which explicitly restricts helping a pregnant minor travel out of state to get an abortion. And I think this is important to keep to pay attention to. Like, our states are going to do that as well. Are they going to start saying like, and not only can you not have an abortion in our state, but you can't travel to those safe haven states to take care of this issue? So just really concerning, especially when, as we'll see, there are medical indications for needing abortion care. Any questions at this point?
This is great information, Alex. Thanks for organizing a complex topic in such an organized way. This is Heidi's voice. I have a question for somebody smarter than me on the topic of licensure. So for people that are working in compact states, and if, let's say, you are a prescriber, you know, what is this like if you are prescribing and the laws are changing? And it sounds like physicians, and I'm presumably any prescriber could be held, I don't know if they're, if it's against the law, I don't know what the right term would be, but what does this mean in terms of compact states? So understanding which state has which law and all of those complexities. Kathy, I know we've talked about this a little bit with the transgender laws, but I'm curious about this.
Yeah, Heidi, I think it's the same thing, that you have to know if you're practicing on a compact license, you have to know what the scope of practice is and what the laws are in the state where you're practicing, which is, could be Texas, could be Idaho, could be, and it's not just prescribing, but it's also counseling, teaching, those kinds of things too, that could be challenging. So it's the Wild West out there right now.
Yeah, I'm thinking specifically about like you're doing virtual practice or something like that, where you could have patients from different states, how very complex this would be. So that's my 2 thoughts. Sorry.
One piece of that, Heidi, is that you have to be licensed in that state, even if you're doing like telemedicine. So I can't do telemedicine in Idaho unless I am licensed in Idaho as an advanced practice provider.
That's a good point, because the APRN compact hasn't been adopted by very many states yet. So that's a good point.
Thank you for that clarification.
No, good question, Heidi. All right. So I also wanted to bring it back home, because I'm sure you guys are like, well, what do we say here in Minnesota? What are our policies? So in Minnesota, currently abortion is banned at fetal viability, which is generally around 24 to 26 weeks of pregnancy. Our state Medicaid funds do cover abortion for women that are on Medicaid. Our state provides protections from harassment and physical harm for anyone entering an abortion clinic. And then our state has a shield law to protect abortion providers from investigations by other states. So those overreaches from like Idaho, and then I feel like we've heard about similar cases, like the Texas issue where they might try and pursue that lawsuit for people from out of state. We have protections in Minnesota, so if we provide abortion care to people from out of state, we're not going to be penalized for that. And it may cover patients and support organizations. Just a little bit of demographic info about Minnesota, how many women could this affect? We have 1.2 million women of reproductive age. And to put that in perspective, Minnesota's population is 5.71 million as of 2020. Abortion statistics. So the most recent statistics from the Guttmacher Institute are listed here. That's why the dates are a little bit back. But in 2020, we had 11,060 abortions performed in Minnesota. And then to put that in perspective, well, how many births occurred in Minnesota? So in 2021, we had 64,425 live births. So about 20%. The rate ends up being 10.2 abortions per 1,000 women. And then in 2017, we had 7 clinics that provided abortion care in Minnesota. just to kind of compare ourselves and see how that looks compared to other states. So I thought Texas, that'll be an interesting one because this data is from 2020, which is again before Roe v. Wade was overturned. So the statistics are going to change in the years to come since abortion is now banned in Texas. But back in 2020, there were 58,030 abortions performed in Texas. They have many more births. They had 373,000 live births, similar rate, about 20%. And then, or that you can see here, the rate was similar, 9.5 abortions per 1,000 women. And they had 21 clinics that provided abortion care back in 2017. One more state I want to hone in on, our neighbor, South Dakota, because this one's kind of interesting. They had limits on abortion even prior to the overturning of Roe v. Wade. And I don't know if because Roe v. Wade allows states to, or limits how states can regulate abortion, I'm kind of surprised that they didn't really have abortion there back in 2020, but I wonder if it just had to do with, the size of the state being small, logistics. Maybe it was easier for people to come to Minnesota for abortion care. As you can see, we only have 7 clinics in Minnesota. It's not very prevalent. There aren't tons of clinics available, but South Dakota really didn't offer much abortion care even prior to the overturning of Roe v. Wade. So in 2020, they only had 130 abortions. They had 11,000 live births. Abortion rate was extremely low, and they only had 1 clinic that provided abortion care in 2017. So I think back to that statistic we talked about in Bloomington, where they were seeing about 20% of their patients coming from out of state, even prior to the overturning of Roe. Well, it's not that South Dakota women weren't having abortions. It's likely they were getting them in other locations. And so just to kind of close up that first objective, so 1 year post-Roe, the abortion landscape, from my perspective, the abortion landscape is increasingly restrictive and very patchwork. As you can see, it's so variable state by state. And then there are different laws aside of just, is abortion legal or not? There are restrictions on you can't help certain individuals get an abortion, or it could result in a lawsuit or legal consequences. So I'll bring it to you guys again. Are there any questions or comments anyone would like to share at this point? All right. So I'll go on to my second objective. So my second objective was to review conditions where abortion is medically necessary. And I want to start by sharing this joint statement that I found. So the American College of Obstetricians and Gynecologists, that's one group, and then the Physicians for Reproductive Health, they released this joint statement. They said, the science of medicine is not subjective, and a strongly held personal belief should never outweigh scientific evidence, override standards of medical care, or drive policy that puts a person's health and life at risk. Pregnancy imposes significant physiological changes on a person's body. These changes can exacerbate underlying or pre-existing conditions like renal or cardiac disease and can severely compromise health or even cause death. Determining the appropriate medical intervention depends on a patient's specific condition. There are situations where pregnancy termination in the form of an abortion is the only medical intervention that can preserve a patient's health or save their life. As physicians, we are focused on protecting the health and lives of patients for whom we provide care. Without question, abortion can be medically necessary. And so I just want to share some of the things that I found. A couple of them I knew about, but I learned more. And I want to give a special thanks to Colleen Quinnell, who works in women's health and did help me familiarize myself with more situations where abortion care could be considered medically necessary. So the first one, ectopic pregnancy. Many of you have probably heard about this before, but in case you didn't, I'll just kind of recap. An ectopic pregnancy occurs when a fertilized egg implants and grows outside the main cavity of the uterus. This can be in the fallopian tube, but it could also occur in the ovary, abdominal cavity, or cervix. The fertilized egg will not survive in this scenario, and the growing tissue can, rupture that area and cause life-threatening bleeding if left untreated. For patients that have had previous C-sections, the embryo could also implant in the uterine scar, and it's considered non-viable at that point. Another medical condition which doesn't threaten the life of the mother, but is still considered an indication for abortion would be severe fetal abnormalities, such as anencephaly, where the fetus has a brain stem, so they have a heartbeat, but they're missing parts of their brain and skull. And if this child is born, life expectancy is typically hours to days. There are also situations where both kidneys are missing, so the fetus can't survive once separated from the mother. Or there are situations where they're conjoined twins and they typically end up stillborn or die very shortly after birth. Another condition is severe preeclampsia. And this is more than just having high blood pressure. In this situation, the woman is also showing signs and symptoms of severe headaches, vision changes, shortness of breath due to fluid backing up into the lungs. There could be protein in the urine, which suggests kidney damage. And as a reminder, if you damage your kidneys, you don't grow those nephrons back. If you damage your kidneys severe enough, you could end up on dialysis. So typically, we try to manage those conditions with medications, but if that's ineffective, the recommendation could be to deliver the baby. And it may be at a time in the pregnancy where it's non-viable. It could be at 20 weeks. And so the recommended treatment is abortion. Missed abortion is when there's a non-viable pregnancy. In this situation, the embryo stops developing, and there still may be like placental tissue and embryonic tissue. And this typically occurs during the first trimester when there are chromosomal abnormalities. And abortion care is, or an abortion is the recommended treatment for this. And then one other situation, while it's uncommon to be diagnosed with cancer while pregnant, it does happen. One study suggested that one breast cancer diagnosis occurs in every 3,000 pregnancies. Cancer cells fortunately don't pass through the placental barrier, but there are concerns about cancer treatment while pregnant. Depending on the type of cancer, surgery may or may not be an option while pregnant. Research has shown that chemotherapy is generally safe during the second and third trimesters after the baby's organs have fully developed. But radiation and hormone therapy are typically delayed until after the woman has given birth. And in some scenarios, a pregnant individual may choose abortion so they can pursue treatment for their cancer. Restricting abortion can mean delaying certain interventions, and that person's prognosis can worsen. There are also situations where medications or procedures used for abortion care may be used for non-abortion care. So, sorry, give me 1 second. So mifepristone and misoprostol, or Mifeprix and Cytotec, these are medications typically, again, prescribed together to induce abortion. We talked about the abortion pill, but they do have other indications. Mifeprix is sometimes used to treat Cushing syndrome, as it can help lower cortisol levels, and Cytotec is used to prevent ulcers in patients taking NSAIDs. As for procedures, dilation and curettage is a procedure, or DNC, is a procedure used to remove tissue from inside the uterus. It's the same procedure used for abortion, induced abortion, but it's considered abortion if fetal heart tones are present prior to the procedure. And DNC is also used to treat cancerous growths in the uterus and remove non-cancerous growths like polyps. So I want to take a moment real quick to share a personal story. When I first heard about the overturning of Roe v. Wade, I saw things on social media about how DNC is just another term for abortion, except it's not. I mean, technically, yes, it's the same procedure, and some people might refer to induced abortion as DNC to keep that language procedural, but I've had a DNC and I've never had an abortion. Back in 2017, my husband and I did a fertility workup because I was struggling to get pregnant. I had a hysterosalpingogram where they do imaging of the uterus, and it showed that I had uterine polyps. Uterine polyps don't always cause infertility, but when they're present, the body might interpret the uterus as being occupied. It has those polyps, and so there's no place for a fetus to develop and grow. And so you might not get pregnant until you have those removed. In January, I had the polyps removed, and it's noted in my chart as a DNC. And by March 2018, I was pregnant after 1.5 years of trying. And I share this because with the current climate of restricting abortion and allowing for civil suits in Texas against those who aid and abet abortion, I can just see providers walking away from anything that's even a distant cousin of abortion due to the liability. And so procedures needed for other reasons can be delayed. They're trying to restrict abortion medications, even though those can be used for other indications. And we don't know if they're going to try and touch on any kind of procedures that are related to abortion care. So I just want to highlight this because we really need to be aware of the implications of all this legislation that's moving forward. And as medical professionals, we're the best ones to share what impact these changes, these laws are going to have on our patients. And so my last objective, I just have a few more slides, and then I have some questions to hopefully facilitate some discussion. I want to discuss the role of the nurse as an advocate for access to abortion care. I think, abortion is kind of one of those things where if it doesn't affect you or doesn't affect your patients, you might be like, well, I can kind of stay out of this conversation. But I think we should look to the ANA's position statement and see that we should advocate for this, for allowing it to be a conversation between medical providers and their patients. And so here is the ANA's position statement on sexual and reproductive health. This statement, as you can see, is from March 7th, 2022. So before the overturning of Roe v. Wade, but this was, again, after Texas started allowing civil suits. So this is at a time when it was a really hot topic, and this continues to be their current position statement. ANA affirms everyone has the right to privacy and the right to make decisions about sexual and reproductive health based on full information and without coercion. Nurses are obligated to share with their patients in an unbiased manner all relevant information about sexual and reproductive health choices that are available and support that patient regardless of the decisions that patient makes. Abortion is a reproductive health alternative that nurses and other providers can discuss when counseling patients. Sexual and reproductive health care should be widely available, accessible, and affordable for all. And nurses have the right to refuse to participate in sexual and reproductive health care based on ethical grounds, as long as patient safety is assured and alternative sources of care have been arranged. So there are 4.2 million registered nurses in the United States. I'm sure among this large pool of professionals, there are some differing opinions on whether induced abortion is ethical. And even then, it's not a black and white issue. I'm sure our views are on a spectrum. In Minnesota, we limit abortion to that 24-week mark of pregnancy. And others may feel that, some may feel that it's unethical to provide induced abortion that late in the pregnancy, but others may feel that abortion should be allowed anytime for any reason, and it's the woman's decision. But I'm not here today to lead a discussion on, the overall ethics of abortion or when does life begin. I'm kind of here to talk about what is our responsibility as nurses when it comes to abortion care. And the ANA really does make that clear. We need to stay educated about this topic. When I was preparing for this presentation, I knew a couple situations where abortion was medically necessary. But as I prepared for this presentation, I learned of several other situations. We have politicians with no medical knowledge talking about this subject, influencing policies and laws, and we really need medical professionals to stay engaged in the topic, provide accurate information, and advocate for access to abortion care, especially when it's medically needed. And then secondly, we should be providing factual, unbiased information about abortion care that allows the patient to decide for themselves what's best. We aren't obligated to participate in providing abortion care if it's against our personal ethics, but we do need to make sure patient safety is assured and that an alternative source of care has been arranged, just as the ANA has stated. So that concludes my presentation. I do have a couple of questions that I was hoping we could discuss. One, what do you think the role of the nurse is in advocating for access to abortion care? Do you agree with ANA's current statement? Do you feel like it goes far enough? And then secondly, what are your thoughts on the overturning of Roe v. Wade? How can medical professionals make sure our voices are heard when it comes to legislation that's going to affect our work and our patients? And I'll open it up to you guys. You can either ask questions about the presentation. I saw that Colleen is on today's call, so she might be a good one for any specific questions about women's health. And then if you guys want to share your thoughts on these discussion questions, I would love to hear them.
We just want to say, I think you did such a great job. It's so much information and it's so well put together. So great work.
Thank you.
So I guess I can start with the role of the nurse in advocating for access to abortion care. I think that the ANA's current statement is really important, and it goes not only for abortion care, but around vaccine policies and some of the other things that we're seeing as care providers today, that if we don't necessarily want to do it, it doesn't, that putting our own personal beliefs into what we do as care providers isn't really appropriate. And that and the least you should do is be able to refer your patients to people who can care for them. And so I think it's really important that that is made a stronger kind of policy, because I know that it is definitely not in practice, at least in the places that I work and have worked in my life.
Colleen, could you say a little more about that? About how it should be stronger? Like what language should there be?
Yeah, I mean, I don't really know, because I'm not, I don't know that much about the ethics statement and some of the other things. I just think, so one of the things I think about is when I was coming up as a women's health nurse practitioner, I worked in a private practice and some of their family doctors didn't prescribe birth control or Plan B, and then actually tried to persuade patients not to go on birth control for heavy periods, not for contraception. And so when you hear language about not wanting to do it, it's really hard to undo that kind of policy. And so there should be something for providers in general where you just say, this isn't something I do, but this person does it. And it should be just part of the foundational training that we all have, because patients look at you for advice. And if you're telling them, nope, I don't do it, and then going into reasons or whatever, then other than it's not something I choose to do personally or provide for, I think it's really hard not to keep that kind of in the back of your head. Oh, maybe I shouldn't be on birth control, or maybe I shouldn't have Plan B, or maybe I shouldn't, whatever, when all of the options are available to everybody. And you should really know consent means that you know what all of your options are and you have the right to use them or not. And so I just super frustrated when I hear so many patients talk about how other providers have either spoken to them about the care that they want or requested or wouldn't give it to them. And it's really, really common.
I want to just add a comment on the top of that, Colleen. In that I'm not sure that everyone knows that Plan B is an over-the-counter medication in Minnesota, and that does not require a provider to write that prescription.
Yeah, it is not as cheap though, if you get it provided by your provider in an insurance kind of coverage place. So yes, and you can go to Plan B and actually, to Planned Parenthood actually and ask for it there, and they'll give it to you most of the time, I think. And there are places that will send it to you for free, but I think that for a lot of adolescents who are, nervous, it's really hard to go to a pharmacist and say, I want Plan B. So if you're in a provider encounter and you can prescribe it, it's almost always cheaper, because Plan B is like $50 or something if you buy it over the counter. And so, yes, I love that it is available to everybody who has to ask for it, but the asking part is the hard part for some people, especially if it's not in that nice safe space of a clinical encounter with somebody that you trust.
Colleen, what is the time frame? 72 hours?
Up to 5 days.
Up to 5. Okay. A piece that I also thought was important is Canada has the right to die laws, and Canada is still over 50% of their populace are identified as practicing Catholic. And so there is some conflict with that. And so they wrote into their legislation for pharmacists and prescribers, nurse practitioners, and physicians, if you are unwilling to provide that service for a patient who's requesting it, that you are legally obligated to refer them to someone who will. And I think in Minnesota, we could strengthen that language so that it is imperative that if you are uncomfortable with that, you have the obligation to serve all of that patient's needs.
I love that language. I think that's really strong.
Yeah, I'd like to say a few things. I was an OB nurse early on in my career, and that religious evidence that you just identified is really a key point. It ties into the ethical aspect that we have with ANA, but I think some people, 50 years ago would look at abortion as a ritual thing. You couldn't do it in Catholic hospitals or Catholic facilities. So the patients who wanted an abortion had to find some other facility locale to do that. So I think if we looked at our ethical perspective, what you just said, if that you from an ethical or religious perspective don't feel that you could help with an abortion experience, that you need to find the patient some perspective to get it. But that we as individuals need to think about that aspect of this particular topic from a legislative perspective right now, and certainly from a nursing perspective.
I agree.
It's interesting too to think about besides abortions and reproductive health care, but thinking about other things like the vaccine hesitancy or whatever, and how to strengthen the language that we use even amongst ourselves. And I know that ANA Code of Ethics will be under review and revised coming up shortly, and Martha Turner is involved in that process, and we'll be doing a program for us on that in the future. And so getting that into her thinking about being really explicit about, what is our obligation to ensure that that patients have all the information they need. And I liked the way too that you tied it in. I think Colleen, you said it into the informed consent. You don't have informed consent if you don't have all the information.
Yes, it's been
Yeah,
kind of one
well
of
said.
the things I've been focusing on recently in my work, and trying to get some of the people I work with to pay more attention to consent, because I don't really think we use it to the way that we should. Sorry to interrupt, Heidi.
Christy, I see you have your hand up. Go ahead.
Hi, I just wanted to say a couple things that I've just been excited about some of the things that Minnesota has done to get rid of some of the barriers that even Minnesota has had before, including that 24-hour and the notification and the parental thing. I worked at Planned Parenthood early on in my nursing career. So it was about maybe like 15 years ago. And I did work at their abortion clinic when it was on Ford Parkway. And I just want folks to know who maybe haven't been part of that type of a working team. The ethical questions that are brought up in this discussion and many other discussions are sort of carefully navigated there too. People have a lot of I think what I experience, and I can't say this for anybody who's been on this type of team or for everybody, but we talked about these things a lot, and personal feelings. And I think everyone came to the table saying that we just want to provide care for people, and that was the main reason for being there. So I think I just wanted to put that perspective out there.
Thank you, Christy.
I think there's some really courageous people working on this issue too. It's Dobbs v. Jackson, whatever, the clinic. The people who were in the Jackson clinic have opened a clinic in New Mexico and are continuing to provide care and are providing it in other places. And they just, they're not just like laying down and saying, well, I guess we just can't do that. They're really fierce advocates for their patients and for people to have the right to get the health care that they need.
Yeah, I think it's Whole Women's Health. So Whole Women's Health is the one that was a part of the lawsuit. And they do really great work.
It's Christy again. I just remembered something I was going to say, which is even though certain states, including Minnesota, provide abortion procedures until like a certain gestational age, there are many providers who don't provide up to that. So I think it's important to remember that those like second trimester, especially like second trimester procedures are much harder to find providers for that. So just thinking about, that will also affect, as Alex was talking about, our access within Minnesota and for our neighbors and other people seeking care here.
I am just thinking about how, as I'm reading through these statements, how do we encourage schools to have students really enter into a space where they're uncomfortable and doing counseling and support for patients to make their own choices, right? And I remember when I was in college, so it's been a minute, but and we had speakers that would come in that frankly, I'm not sure, even in places like universities that allow speakers. I remember listening to Sarah Weddington talk about her experience as the attorney and how young she was and how unbelievable this experience was, and that it took so much courage to just move forward when no one else would do this. And I'm like, I remember listening to her thinking, she really put her life and her career, in a tricky spot to advocate for something that she truly believed in. And do we do that, or do we encourage our students to do that, or do we just say you're not comfortable or you don't believe in it, so you don't have to worry about doing the advising or counseling? I don't know. I was a public health nurse, and when I worked with young women, I worked with women who have chosen to have abortions. I've worked with women who have chosen not to have abortions. I've worked with women who have chosen to have abortions and then at the last minute chosen not to, and supported them through their pregnancy and work with their children. And it's like, it doesn't matter. It was their choice at the end of the day. And you just support people in the choices they make. I don't know. I just think we don't always have the opportunity to really challenge that piece, which is sometimes you're the caregiver first and you have to put your own opinions, whatever they may be, aside so that you can advocate for what they want. I don't know. That's just my thoughts on this, but thanks for your presentation. Good job.
Thank you.
That was really well said, Janine. This is Heidi and her assistant here. one thing I just wanted to share, my daughter was a brand new PA, fresh out of Iowa medical school and was working in Detroit Lakes and in the ER and was caring for a patient who had hyperemesis gravidum and so sick, in and out of the hospital for IV fluids. And, you know, was trusted Emily. They were similar age and said, I think I want to have an abortion. I just can't go on like this. And she had said the same to the nurses, and Emily went out to the station to overhear the ridicule in their voices for this woman's statement. And Emily said, I just can't believe the heartlessness. And the same team of nurses and physicians had others opinions about other people's lifestyle choices too. But it was kind of her first experience of working in a place that was so heavily biased. And it kind of it broke her heart. And now where she works is also rural, but not of the same bias. But it is heartbreaking to see that in some places of care.
I just wanted to tell people that I put a link in for the story on Sherry Chesson. She was the romper room lady who had taken thalidomide, who went to Sweden to have the abortion. I believe that she also did an interview. I think it was NPR, but I'm not positive. But her story, she is recorded doing it. I think it's NPR. I didn't have time to look it up. Is very, very touching. And it's worth taking a look at, you know, if you're thinking about sort of what is that other perspective from the inside of making these horrible decisions. Here's a woman who's devoted her life to children and realizes that she can't deliver this baby because it's probably severely handicapped. And again, you know, these are the days before we ultrasounded everything. And it's quite an amazing story if you have a few minutes to read it.
I see Mary Absalon has a question. Do school-based clinics offer any type of abortion services in Minnesota? Anyone know?
I don't know the answer to that, but my likely guess is no, that not specifically on school campuses. I think the University of Minnesota is trying to organize medication abortion on clinic, but as far as I know right now, it's not a thing at their campus either. But I have some midwife friends who work in the public schools and their clinics, so I do know that they talk about referrals and things like that, but as far as I know, they don't provide services.
So is there anyone besides me who gets really fed up with male legislators talking about how easy it is to be pregnant and how easy it is to have a baby and how you know, there's no pain involved, there's no nothing involved, it's just like simple?
Yeah. You're more likely to have a complication in pregnancy than just about most things. Like, so the things that you can get, just like was reviewed, the high blood pressure, cardiac disease after pregnancy. I mean, pregnancy is not risk-free. And abortion is medical abortion anyway, and in-clinic abortions, which is another term for like DNCs, are safer than taking over-the-counter Tylenol in a population health stance. Of more people have harm from taking over-the-counter Tylenol than any kind of complications that come from using the abortion pills together or a side effect by itself. So they really, really are safe. They just have so much stigma around them, but they are safe medications for most people.
Kathy, the other thing I was thinking about as I was preparing for this is nurses are very underrepresented in politics. Because again, I told you guys 4.2 million Americans are registered nurses, or not just Americans, but people in the United States are registered nurses. And we're just severely underrepresented at the state legislator level and the national one. It's hard because I myself am like, well, I wouldn't want to be a politician. I think a lot of people of us are like, I want to stay away from that. But like, how do we get that medical knowledge to that level to help influence laws?
You'd think that you'd be able to teach without actually having to run for office yourself, but that's maybe naive.
Good information. I appreciate it. And I always learn so much from these. So thanks for doing such a good job on bringing together great speakers.
Yeah, thank you guys for coming.
Thank you, Alex from Heidi.
Yeah, thanks, Heidi.
Great presentation.
I agree. And Alex, you showed the courage you're asking us to have to even bring the conversation forward. So
Yeah, thank you.
So I think, I'll be sending out an evaluation, and then once you've completed that, you'll get a certificate of attendance. And really happy you came tonight, and lots to think about. Heidi, any closing thoughts?
I have a almost 2-year-old with the meltdown.
That's okay.
Sorry, Kathy. No, just great thanks to Alex. Appreciate it.
Yeah, thank you
Yeah.
guys.
Thank you so
I'll
much.
see you guys at the next meeting. Have a
Right.
good night.
Thanks.
Right.
Good night.
Thank you,
Bye.
everybody.
Bye.